A concept that I've had to purge from my brain since starting in critical care is that CVP is equal to fluid, which is then equal to preload. Now, CVP is a measurement of pressure. This pressure is measured near the right atrium. While preload is a mechanical property, it's the amount of stretch that the muscle is experiencing before contraction. So there's a lot of things that can affect CVP and not necessarily affect your preload. So if we're talking about PEEP, if we increase our PEEP, we can increase the intrathoracic pressure in the chest, right? And that will increase our CVP. And just because we are increasing pressure doesn't mean that we are increasing preload. There's nothing to increase the stretch of that heart. So we see an increased CVP with a non-affected preload, and sometimes even less preload because we're decreasing the amount of blood coming back to the heart. And then also, if we have a ventricle that is not compliant or stiff, the pressure can back up into the right atrium and we can have a higher CVP there and not a higher preload. We have a stiff ventricle that is not allowing for more stretch. Now, while we shouldn't be using CVP to directly measure preload, we can use it as a trend. And as long as we're not changing anything else, like we're not changing the PEEP, if we're seeing a rise in the CVP, that means that there is something that is going on in that ventricle, and it could be increased preload. But we need to see it as a trend, and we can't take snapshots. We need to see the whole picture in order to correlate these two things.